As a doctor who specializes almost exclusively in diseases above the neck, I'll admit that pregnancy is extremely foreign to me. It's terrifying, actually. It's like when I get that call from the emergency room or the OB observation unit, and I hear that it's a 20-something-year-old woman with any kind of complaint. I immediately begin to panic. I mean, even with the simplest of complaints, all I can imagine are the scariest complications: pulmonary embolism, HELP syndrome, fetal distress, miscarriage. And these aren't even neurologic. Above the neck, I'm worried about eclampsia, PRES, a lower seizure threshold or fluctuating anti-epileptic drug levels, venous sinus thrombosis, and RCVS.
Although these things are all uncommon.
This is Dr. Jonathan Edlow of Beth Israel Deaconness Medical Center in Boston.
I've been practicing for about 37 years, so I think I've seen all of them at least once, and some of them more than once. And as a neurologist, you will see them from time to time.
And if you haven't seen them yet, then you should absolutely be thinking about them, because they aren't conditions that you'll want to miss. And while you'll be working close alongside your colleagues in the ER,
this tends to be a team sport.
Your friends in OB-GYN or maternal fetal medicine,
maybe neurocritical care as well if you have that available,
neuroradiology,
all of these different people.
For the most part, you are the neurology expert, and they will be relying on you for the next steps in management. Welcome back to another week of the BrainWaves podcast, a show about neurology and medicine and all the fascinating science and history that comes with it. This week on the program, Dr. Edlow, an emergency medicine physician at BIDMC, is going to give us a roadmap to help us navigate through some of the common and some of the not so common acute neurologic complications of pregnancy. Stay with us. Hey, Dr. Edlow.
Hi.
Well, thanks again. For this week's program, I was lucky enough to get on the line with Dr. Edlow to talk about some of his experiences in the emergency department.
My pleasure.
Dr. Edlow serves as professor of emergency medicine at BIDMC in Boston, and he's the vice chair of the Department of Emergency Medicine, a role he's served over the last about 20 years or so.
I became somewhat interested in neurologic emergencies and the diagnosis of them in pregnant and postpartum women, just because it's such an anxiety-provoking situation for all of us.
I couldn't agree more with this. But the more I talked with Dr. Edlow, the more I was able to learn about his approach to some of the major complaints that women of childbearing age present with, and the concerns that we should have when evaluating them. For the listeners out there who want more information than what we're about to cover, I'd highly recommend that you take a look at one of his multiple papers on the topic, and you can find them referenced in the show notes. But before he and I dove into the complications of pregnancy, I did try to pick his brain about something else. So what do you think about the podcast?
I liked him. I listened to the acute vestibular syndrome where you talked about one of your colleagues.
And he had some good tips, actually.
I think the part of it that was underplayed was the importance of putting a patient into a timing and triggers category. You were focused on the acute vestibular syndrome, but I sort of see it in one step forward where a dizzy patient comes in and I have to figure out, is this episodic? Is this continuous? If it's episodic, is it triggered or spontaneous?
I kind of like that. I will say that when I had Ali Hamidani on the show to talk about acute vestibular syndrome, that's also how he categorized the various causes: intermittent, positional, acute and constant, and so on. But it really goes to show you the value of the opinion of somebody outside your own discipline.
Yeah, it's definitely a different perspective.
And I think this definitely made for a good interview for today's program. All right, here's the show. So I think it's safe for me to say that whenever I'm asked to weigh in about a patient and I hear something starting off with, this patient's a 24-year-old pregnant woman, I immediately begin to panic. There are just so many things to consider. And more often than not, women who are pregnant, they may have minor neurologic issues that we as neurologists and you as an emergency medicine physician, we don't necessarily see, issues that are kind of common or benign. When you see a patient who comes into your ER and they happen to be pregnant or they test positive with urine pregnancy test, what's your threshold to call that neurology consult if the concern is neurologic?
Yeah, so I think that my threshold and one's threshold should be extremely low. The reality is that, as you mentioned, many of these patients have minor issues that they've already spoken to their obstetrician or their primary care doctor about. So one's dealing with a selected population by definition once they've reached the emergency department. And I think, some of that low threshold and anxiety comes from the fact that you're almost always dealing with a young, healthy patient. And anytime one has a young, healthy patient, they're just the stakes are greater. Secondly, you've got two patients. You've got the fetus and you've got the mother. The third thing is that the differential diagnosis is just a little bit different, and one has to think about other conditions, many of which are relatively uncommon. And the next thing is that, CT, which is the usual initial go-to test for most patients with acute neurological symptoms, which is perfectly safe to do, often doesn't give an answer. And one has to be careful not to overly rely on a negative CT. And then finally, there's the medical legal threat. If things go bad, they can go bad quickly, and one can find oneself embroiled in a medical legal issue.
And I think that's a great transition because you as an emergency medicine doc, you get to see and you have to manage a lot of these really life-threatening and time-specific kind of conditions that we as neurology consultants, we don't necessarily get to see. And before we even get into the neurologic complaint, briefly, can you kind of walk us through what you have to do pretty quickly to evaluate for concerns that pregnant women come to the ER with?
Sure. So the first is, for a moment, forget they're pregnant. And I say that in a very specific way. One always needs to pay attention to the ABCs. So if there's an airway issue, one needs to deal with that before you even go forward for the rest of the case. In trauma patients, for example, the general principle is that you treat the mother first. And you're not going to have a good fetal outcome if you've got a physiologically altered mother. So you really need to make sure that you pay attention to the mother, go through basic principles about ABCs, and then you can sort of step back and think about some of the, special circumstances that we're about to speak about.
And before we get into these special circumstances, like a young, healthy woman who's pregnant and suddenly develops a new neurologic problem, Dr. Edlow is already classifying the patient as having a viable pregnancy or not. Viable meaning that the pregnancy has reached at least 20 weeks gestation and could survive a premature delivery if necessary.
So if it's a patient who's, 10 or 12 weeks pregnant, I may be concerned about various neurological issues.
But at that point, if it comes down to the patient or the fetus, the patient always comes first.
Once you get to, 21, 22 weeks, the situation becomes a little dicier.
Dicier meaning decisions often have to be made about whether, in somebody who has eclampsia, for example, to attempt emergent delivery to save that potentially viable fetus, as well as the mother. Or do you maybe push the envelope a bit and see if you can't get the fetus to a more mature state, maybe just a little bit before expediting delivery?
One thing that you always want to get are thinking about eclampsia and preeclampsia labs. So liver function tests and platelet count and uric acid are things that we would get with a lower threshold than in a non-pregnant woman.
In kind of creating this episode, I thought that it'd be easy to kind of divide up the topic into various chapters. The first of which would probably be headache. It's one of the most common complaints that we see in the emergency room. And when headache is a concern in a woman who's pregnant, I always feel like we have to proceed with an MRI and an MR venogram because it's a very litigious complaint and it's something you absolutely don't want to miss. And you mentioned CT scans are something that we tend to avoid, but why do we feel like we have to go down this route of MRI and MR venogram?
Well, again, I'm seeing a select population because they've made it to the emergency department, and you're seeing an even more selected patient in whom, at least in the judgment of the emergency physician seeing that patient, it's something that they need a neurological consult for. So you're seeing kind of the top of the food chain group of patients, and I think that by the time they get to you, they probably do need to have a venous sinus thrombosis ruled out. So that instinct to get, an MR, MRV is a reasonable one. I would mention that for venous sinus thrombosis, CTV is pretty much just as good if you're just worried about cerebral venous sinus thrombosis. So if you found yourself in a hospital that's a peripheral hospital where you don't have access to MRV or MR of any type, One could do a CT venogram and get pretty much the same sensitivity.
Is contrast a concern?
So iodinated contrast for CTs is much less of a concern. Gadolinium is a problem.
Maybe that comes as a surprise to you, that gadolinium exposure is a problem. In a prior episode of the show, we discussed the risks and the benefits of gadolinium chelates in MRI, but glossed over issues faced by pregnant and lactating women, kind of in preparation for this episode. Before 2016, most guidelines discouraged the use of any gadolinium-based contrast agent in a pregnant woman unless it was absolutely essential. The concern being that gadolinium had been known to cross the placenta, and that there were theoretical risks to the fetus during organ development. Now, this was entirely unproven, all theoretical. But in 2016, an observational study was published in JAMA, looking at almost 1.5 million deliveries in Ontario, Canada, with the aim of comparing risks of adverse fetal outcomes based on gadolinium exposure. MRI use was minimal, only about 4 MRIs for every 1,000 women. And MRI alone was not associated with any statistically significant risk to the fetus. However, gadolinium usage during the first trimester versus no MRI was associated with a 36% increase in the risk of any rheumatological, inflammatory, or infiltrative skin condition. And stillbirths were nearly 4 times as likely. But this was a retrospective cohort, and although that the authors used propensity matching to adjust for confounding variables, it does raise the concern that gadolinium is not perfectly safe. So why not just use CT?
So I think that in general we overblow the concern about the radiation exposure for the fetus.
While it's important to be aware of the risk of radiation, like Dr. Edlow's saying, being concerned with growth restriction, birth defects, mental retardation, and cataracts, these risks are extremely rare when the appropriate precautions are used.
CT is perfectly safe in pregnant women.
You can shield their belly with a lead apron, and you can limit the windows for radiation exposure. But more importantly, when you're considering the risks and the benefits of getting the scan, whether it's a CT or it's an MRI, always remember why it is that you need the study.
There was a study, a British study, about almost 350 patients that had pregnancy-related deaths. And one of the common themes that emerged in that was the fact that people were often hesitant to do brain imaging with CT, which we shouldn't be.
This takes us back to the beginning of the show, when Dr. Edlow said that in these circumstances, you've got to remember that, although it's just one person in your ED or in your clinic, you're actually treating 2 patients. So now that we've covered the safety concerns with imaging, let's think about getting that imaging for the patient and working her up for the headache disorders. What other things should we be concerned about in a pregnant woman?
Yeah, so first of all, just like in headache patients in general, the most common causes are the benign primary headache syndromes. Migraine in the majority of pregnant women tends to get better if they have a pre-existing diagnosis of migraine, tends to get better during the pregnancy and then come back worse after the pregnancy. That said, if there's anything a little bit that spooks me in the history or the physical that makes this atypical for a migraine for that patient, I'm pretty likely to work them up.
Meaning getting the imaging you need to rule out PRES, as you would see in eclampsia, to look for some tumors that may grow in pregnancy, like meningiomas and pituitary adenomas. And then, of course, your venous sinus thrombosis.
Probably 75-80% of patients with a venous sinus thrombosis happen in the very late 3rd trimester or in the several weeks postpartum.
And then a smaller peak at the beginning in the 1st trimester, usually for women who've already had some predisposition to clotting, as Dr. Yuan discussed in episode 128 on thrombophilia testing.
Pregnancy. So there is that early presenting group, which is a smaller group, and then the later presenting group, which is the majority.
So the next question is, when should you suspect a venous sinus thrombosis? You've ruled out the milder headaches, or you've ruled out typical migraines in your migraineur, which is super common.
Half of those patients still had migraine or tension headaches at the end of the day.
What else can raise your pretest probability that the headache is due to a sinus thrombosis if clots can occur at basically any time during pregnancy?
There's nothing particular about it. Approximately 10% of the time they will have a thunderclap headache, but that means that 90% of the time they won't.
And of course, with thunderclap headaches in a pregnant woman, you'll also be thinking about pituitary apoplexy if there's vision impairment or double vision from some cranial nerve compression. You'll be thinking about aneurysm rupture. And it's not classically taught this way, but you should also be thinking about eclampsia. During our interview, there was one paper that Dr. Edlow and I talked about, looking at the causes of headache in pregnant women. And eclampsia, it was up there.
I think it was 20% or so, I don't know the exact percentages, had preeclampsia and eclampsia. Another 10 or 12% had a post-dural puncture headache.
Which is almost always due to epidural anesthesia.
But it's important to remember that just from labor-related pushing, patients can develop small dural tears and have a syndrome that's a positional low-pressure headache, like a spontaneous intracranial hypotension.
And just to reiterate, all of these secondary headache syndromes seen in pregnancy, the pituitary apoplexy, the brain tumor growth, and venous sinus thrombosis, these are all far, far less common than the primary headache syndromes that you see in these patients.
The venous sinus thromboses in that paper were only about 3% of the 100 women. So even in that rarefied population of patients admitted postpartum for a headache that was a bad headache, only about 3 out of 100 had a venous sinus thrombosis. And then I think there was 3 or 4 pituitary apoplexies in there as well.
So ultimately, these are all very rare conditions, but something that we absolutely don't want to miss.
Yeah, I mean, obviously, you want to diagnose a venous sinus thrombosis when it is just a headache, and you can treat it and avoid short-term complications.
Next, Dr. Edlow and I moved on to preeclampsia and eclampsia, disorders which may complicate almost 1 in 20 pregnancies, according to some data, and they may be responsible for as many as 10 to 25% of all maternal deaths. So let's start with what preeclampsia is.
Preeclampsia is, the presentation after week 20 of pregnancy in a previously normotensive patient, new hypertension, either with proteinuria or with other visual or neurologic or GI-type symptoms or renal symptoms.
Eclampsia, then, would be all those things, plus a seizure. And there can be other complications as well.
The bottom line is that eclampsia and preeclampsia play a role in probably 30, 40, 50% of pregnancy and postpartum related strokes.
And while we know a great deal about the epidemiology and the management, as we'll discuss in a moment, we're not so certain as to why this happens.
It's not clear, first of all.
There's some sort of a disturbance in placental function in early pregnancy that leads to maternal systemic inflammation.
Some people think it's over-autoregulation where the cerebral arterioles will vasoconstrict and you'll get ischemia.
Or you can have under-autoregulation, and there can be leakage across the blood-brain barrier.
And some people think it's just the hypertension.
It's a mess. But at least we know how to manage it.
Yeah, so, magnesium has been studied, and it certainly is superior to benzodiazepines and superior to phenytoin. So that's your go-to drug. And really the only contraindication I'm aware of is a myasthenic patient with pregnancy and eclampsia, because that can precipitate a myasthenic crisis. The other caution that's important would be a patient with renal failure, although even there you can give a loading dose of magnesium. You just have to be really careful about subsequent maintenance doses. But if you have
Another tricky thing about mag dosing is that there's not really a clear therapeutic level. As a med student, I remember always being taught to titrate it until the reflexes drop out. But the American College of Obstetricians and Gynecology recommend a 4-gram loading dose with a 1 gram per hour infusion for a maximum of only 24 hours, or until delivery can be performed.
Although one can follow levels, and generally we recommend following levels, there's no real therapeutic level for the anticonvulsant activity.
Which you might only follow for toxicity purposes, rather than for therapeutic reasons. But if MAG isn't working, then you may need to escalate therapy.
And it doesn't work. Benzos would be my next choice, and I'd probably use lorazepam or midazolam. And then the other caution there is if the seizures aren't getting better with magnesium, one needs to question the diagnosis of eclampsia. and think about other problems like a venous sinus thrombosis or like a stroke. And pretty much by that point, these patients will have had brain imaging. But anytime in any situation, pregnant or not, that a patient's not responding to what you're giving them, one of the things on that checklist is, do I have the right diagnosis in the first place?
I think that's just such a critical point to make, and not just limiting yourself to this kind of an anchoring bias where you're stuck just holding on to this diagnosis of this is an eclamptic seizure, but it's not actually eclampsia. It's somebody who has a history of epilepsy and they're just not controlled, and they can't give you an adequate history about their medications, and you don't have drug levels. Patients who have epilepsy are going to have children, and you got to be worried about them having breakthrough seizures as well, especially as the hormones kind of fluctuate throughout pregnancy and can affect some of the certain drug levels.
Yeah.
Along the spectrum of eclampsia in pregnancy would be conditions like PRES and RCVS, the reversible cerebral vasoconstriction syndrome. And that's what we talked about next.
PRES, posterior reversible encephalopathy syndrome, which was discovered or first described actually at Beth, Israel, where I work, is something that, to me, there's a huge overlap between it and eclampsia. Now, obviously, PRES can occur in non-pregnant or postpartum women, but when it does happen in pregnant or postpartum women, I think it's just the radiographic manifestation of severe eclampsia. And usually those patients will have a seizure first and then have some, visual symptoms and headache. And any time I hear seizure plus some other thing, especially visual symptoms, I think about PRES. Many of those patients will have hypertension that will need to be treated, but some of them won't.
Just to remind the audience, as we discussed back in episode 22 in 2016, PRES is a comical misnomer. It's not always posterior, not always reversible, and not always associated with encephalopathy. Purely unilateral frontal or temporal lobe involvement in PRES is very common. Maybe 30 to 50% of the time this happens. So I wouldn't count on it being a purely posterior problem. 10 to 20% of cases can demonstrate irreversible ischemic injury, and another 10 to 20% have associated intraparenchymal hemorrhage that's usually always confined to the bed of the vasogenic edema. Or more rarely, you can see subarachnoid hemorrhage along the cortical convexities. Previously called the reversible posterior leukoencephalopathy syndrome, the leukoencephalopathy part was also inaccurate, as vasogenic edema and intraparenchymal hemorrhages would often extend into the cortical ribbon.
And then reversible cerebral vasoconstriction syndrome, the classic case presents relatively typically with multiple brief duration thunderclap headaches.
The average number of headaches is about 4 for your typical RCVS patient, and they can be distributed across several weeks.
Which is almost pathognomonic of vasoconstriction. The reversibility has to do with the vasospasm, but not necessarily with the clinical outcomes.
Because outcomes will be dependent on whether there's associated infarction, which can occur 2 to 3 weeks after headaches begin, or whether there's also subarachnoid hemorrhage.
When you see a convexal subarachnoid hemorrhage, you should think about reversible cerebral vasoconstriction syndrome in a young patient and probably amyloid angiopathy in an older patient.
So evaluating your younger patients for important triggers, like recent stimulant use, SSRIs, triptans, and ergots, all this will raise your pretest probability for RCVS, as will pregnancy, with or without the features of preeclampsia or eclampsia.
And then the other thing is that the arteriogram, be it CT or MR or digital subtraction, can be falsely negative in the first week. So if you have a patient with typical reversible cerebral vasoconstriction, an arteriogram may be falsely negative in the beginning.
That's because RCVS is a dynamic process, and CTA carries a sensitivity for RCVS that's only 70% of what you'd get from a conventional angio. So experts would recommend empiric treatment with calcium channel blockers and withholding the stimulants or SSRIs if your index of suspicion is high, and then repeating that non-invasive or maybe even invasive form of vessel imaging a couple days later. It's important to know that the peak of vasoconstriction in RCVS is not reached at the onset of symptoms, but it's an average of 16 days after the first headache. And some of these clinical clues may help you decide what was the primary cause of the headache in your pregnant patient.
The sequence is that, in general, Venous sinus thrombosis, the headache starts first and the seizure is a later phenomenon. With PRES, it's kind of the opposite. The seizure is often the presenting thing. With vasoconstriction, usually it's the multiple thunderclap headache, so the quality of the headache is different. And then, seizure, which is much less common, would be a later phenomenon. So the details of the history, the phase of the pregnancy, the sequence of the symptoms can often be a clinical clue as to which of those things is going on.
Moving on, Dr. Edlow and I talked about a neurologic complication entirely unrelated to the relative state of hypercoagulability during pregnancy, entirely unrelated to placental dysfunction or systemic inflammation or vascular abnormalities. This neurologic complication manifests rather suddenly, and it can be surprising if it's not appropriately triaged.
Wernicke's. We always think about Wernicke's encephalopathy in kind of Bowery drunk patients, but in one large series of over 600 non-alcoholic patients with Wernicke's, I think it was like 10 or 15% were pregnant women who developed thiamine deficiency because of hyperemesis gravidarum. So if you suspect...
Usually it takes about 2 to 3 weeks of severe vomiting and poor oral intake for your B1 stores to deplete. And recall that Wernicke's is characterized by the triad of ophthalmoplegia, ataxia, and confusion. But you don't need all 3 symptoms to have a significant thiamine deficiency, or for the thiamine deficiency to leave the patient with lasting neurologic deficits, which happens 3/4 of the time in these patients.
I had a non-pregnant case just 2 nights ago where we gave her 500 milligrams of thiamine, and you can draw labs to test for thiamine or enzyme levels, but it's unnecessary, and the diagnosis is partly just give thiamine.
As we're getting close to the end, I wanted to at least acknowledge some of the more esoteric or rare neurologic complications of pregnancy, some of which you may never see, but you'll want to keep in the back of your mind when seeing a pregnant patient. Because, like we said at the beginning of the show, this is a highly, highly litigious field in medicine. For example, when you walk into a delivery room, and the patient all of a sudden has developed new focal neurologic deficits, or she's seizing. In addition to the more common things like eclampsia, stroke, or hemorrhage, you might also be thinking about air embolism or amniotic fluid embolism. In the outpatient setting, this next one's going to be pretty common. Sometimes patients can present with progressive focal weakness due to a compression of a peripheral nerve. In particular, this is seen in sciatic neuropathies or worsening carpal tunnel syndrome as the woman becomes more edematous from pregnancy. And there are other considerations.
Cervical artery dissections is something that the literature is kind of not clear about whether that's really increased in pregnant patients or not.
Generalized weakness or fatigue, which can be multifactorial from weight gain and fluid retention, or even peripartum cardiomyopathy.
The other thing is TPA and ischemic stroke. It's not a contraindication.
There's the unique chorea gravidarum, which occurs in isolation of any other movement disorder, and restless leg syndrome, which could be a manifestation of iron deficiency during pregnancy, or it could be its own idiopathic condition.
And then there's a bunch of rare stuff that, frankly, I've never knowingly seen. Metastatic choriocarcinoma is another very rare event. It gets dicey because there's a lot of possibilities, and the context is what we stated at the beginning of the podcast.
As you're listening to this episode, for the women out there, I'm sure that this all sounds terrifying. All the things that can go wrong as you embark upon one of the most joyous phases of your life.
I've been practicing for about 37 years, so although these things are all uncommon,
most are actually quite rare.
As a neurologist, you will see them from time to time.
But with adequate obstetrical follow-up, the good news is that they are very frequently preventable. Plus, pregnancy is not always bad for the nervous system. Multiple sclerosis is the iconic condition that tends to get better during pregnancy, and these patients generally have fewer relapses. And that wraps it up for another week on the BrainWaves podcast. So grateful that Dr. Jonathan Edlow was able to join me for the program today. For some related content, be sure to check out the podcast on Twitter at BrainWaves Audio or on Facebook as well. The BrainWaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. This week's program was produced by Jonathan Edlow and myself, Jim Siegler. Music courtesy of Daniel Birch, Ian Sutherland, Kevin McLeod, and John Bartman. Sound effects by Mike Koenig and Daniel Simeon. I'm Jim Siegler. Thanks for listening.